Buddy?
Yes, it is visible and audible.
Okay, and I try to make it quick and short. So what we are going to do is we are going to see the procedure, what we see, and how the assessment of post-TAVI patients or post-AVR patients are different in terms of as compared to the native VAR patients. So besides that gradient measurement, effective orifice area, PVL, we will be focusing mostly on PVL because I understand most of our audience are very well acquainted with the idea of measuring the EOA and assessment, EOA and gradient assessment. So for the pre-procedure echo, what we go classically on a transthoracic echo is that standard views we take. We take a peak velocity, mean gradients, and we take aortic wall area by continuity equation. You can use the dimensionless index also. And on top, you always check the stroke volume index because that's where you can diagnose the paradoxical low flow, low gradient aortic stenosis. And whenever there is a discrepancy between the gradient and the symptoms or patient's murmur and the symptoms, we strongly recommend that you use a pedo probe. It's a pencil probe. Change the patient's position. Typically, what we expect that the direction of a jet and the angle of your 2D echo velocity direction should not be more than 20 degrees. If it is more than 20 degrees, we are likely to underestimate the gradients and eventually finding out that you are missing the diagnosis. We can also have a very good idea about AV morphology, like bicuspid aortic valve, type of fusions and everything, but that has less of value since TAVI procedures are predominantly done on a CT scan basis. So this is the standard definition of severe aortic stenosis, as all we know. I will not go into detail of this one. So it is not a challenge when you have a gradients mean more than 40, peak more than 60, ejection fraction normal, calcified valve. We all know this is a severe aortic stenosis. But there are other variants of the severe aortic stenosis which we should understand. Besides having a normal EF and normal gradient, we can have a paradoxical low flow, low gradient aortic stenosis. In this one, the patient's ejection fraction is normal, but because of the severe concentric LVH, LV cavity becomes smaller, and as a result, the stroke volume is less. So the opening of the aortic valve is less. So because the LV does not have enough volume, we are actually not getting one higher gradient because the flow passing through that stenosed valve is not too much. So that's why it's important to check your stroke volume whenever you are doing a patient's or echo of a patient with a severe aortic stenosis. All of us are acquainted with the idea of low flow, low gradient classical aortic stenosis, where the patient has impaired LV function, and as a result, the stroke volume is less, and the resultant gradients are not so high. Earlier, we used to do abdominal stress echo to differentiate between the pseudo aortic stenosis and true aortic stenosis. On top, we used to check the myocardial recovery potential by viability, or how much recruitable myocardium we have. But now we have more and more studies to suggest that in patients with aortic stenosis, even those who don't have a recruitable myocardium, they do better with a valve replacement either by surgery or by TAVR as compared to those who are left on medical management. So what is the normal flow paradoxical low gradient aortic stenosis? The rule of thumb is that you have to find out a stroke volume. If your stroke volume index is less than 35 ml per meter square, that means your flow is not adequate. And in this one, the continuity equation gives you the better idea as compared to you are just going by gradients. And this constitutes a big number of the patient. This is like 1/3 of the patient does not kind of fall into the category by gradients. So whenever you have this doubt, always and always see the stroke volume and just check whether your patient is not falling into the category of paradoxically low flow, low gradient aortic stenosis patient. And whenever you have a doubt that whether I'm dealing with a cardiac amyloid or just a hypertrophic cardiomyopathy and the pseudo aortic stenosis, one of the very important tools which can be helpful is the CT calcium scoring of your valve. If you have a paradoxical low flow, low gradient aortic stenosis, and if you check the CT scan done, if your valve is super calcified, then you are actually be dealing with a true aortic stenosis. This is a different thresholds we have been using. They are different for male and female. But more or less, if the case is with a Augustin score more than 2000 for men and more than 1200 for female, is usually we are using as a cutoff in our practice. But yeah, even in a more paradox, if your aortic stenosis valve has a calcification score of more than 3000 in male, more than 600 in female, then believe me, you are actually dealing with a actual aortic stenosis at the valvular level, or instead of having something infiltration of or hypertrophy of a myocardium. So dimensionless index is one of the other modality. This concept came into the picture after evolution of the TAVI, where the CT scan become the rule, and people have realized that most of the time your aortic annulus is going to be elliptical, and what you are seeing in the LVOT in a parasternal long axis view is the shortest axis of the aortic valve. So once you are checking the shortest axis and then you are measuring that thing, that can be really wrong. Instead, we do not take any denominator. Let's just check differentiation of the velocity between the annulus and LVOT, and then we check the ratio. If your ratio is less than 0.25, that means you are dealing with a severe aortic stenosis. And if that is applicable more when you have either too small or too large of an annulus, because that's the time where you are going away from the value of 1, between like LVOT diameter of like 1.8 to 2.2, that is like radius of 0.9 to 1.1, you are close to 1, your dimensionless index and your continuity equation gives the same picture. But once you are away from that thing, you are likely to be more wiser from dimensionless index as compared to the continuity equation. LVOT diameter measurement, this is something you have to see the hinge point of the leaflet attachment where you are supposed to see. And whenever you are taking the velocity, take it like at least 1.5 to 1 centimeter before the hinge point of those things. That's just one practical tip for the young fellows who just started to venture into the structural heart disease and the valvular heart disease practices. Whenever you are checking the echo, always keep an eye on the septal bulge and just see that actually the gradients are valvular level. If your tracing is like a Draeger shepherd, and if you feel that septal bulge with having some SAM, believe me, these patients are not a good patient right away for any TAVI or a surgical valve. So velocities, whenever you are checked, as I said. Yes. Hello. Yes.
Sir, you have got 1 minute to finish the talk.
Okay, I thought it was 20 minutes. Okay.
Okay.
Okay, then I will go quickly. So this is a PDOC probe where the velocities, as I said, is something we Sievers classification, we go better with this. Whenever you are dealing with a valve-in-valve cases, just check that you don't have a valve dehiscence or a severe paravalvular before subjecting this patient to TAVR. Intra-procedure echo, mostly what the things we want to see is a mitral regurgitation, ejection, LVEF to start with, and the pericardial effusion. Because if post-operatively, post-procedurally, if there is a patient who has got some coronary ischemia, who has got some perforation, and if there is a development of new MR because of the deeper deployment of the valve, you want to be wiser by knowing the background thing, the square one situation from the beginning. So, and in the setting of a patient with a CKD, and where the renal, the coronary CT aortogram is not possible, you can use your 3D TE modalities just as like what you do the CT scan analysis, from which you put your cursors and markers at the hinge point, take the numbers at the lowest point of attachment or perimeter areas and everything, and then you get to know that. But keep one thing in mind, the TE derived perimeters and areas are slightly smaller as compared to the CT scan, and the dropout artifact from the calcium makes the visualization of an entire annular border sometimes challenging in a very sick cases. So this is, as I said, what to see. If there is a PVL, you want to see from the baseline. Annulus rupture, you will get to know from the from your pericardial effusion development. It can happen before or after BAV or after stent deployment. MR can happen during your wire placement, where it can pass through one of the chordae and can cause impingement of the mitral valvular function, as well as after the deep deployment of the valve. And RWMA, this can suggest you about some coronary occlusion. This is a baseline thing what you want to actually know before you go inside the TAVI case for supporting the case. So when you check the deployment, you can check the things at the 2/3 of the deployment, where you just want to see that, check yourself at the annular point, like maybe like here, and the lowest part of the frame, and then you check the depth, at what depth you are actually there. Right, as you can see here, this is a recommended depth diameter on my left, and too deep on the right upper side and too high on the left right lower side. PVL assessment, it should happen in the long axis and short axis both. It is slightly different as compared to what you see here. Here you want to be actually at the annulus level, not something at around sinus. As you can see on the left, you want to see actually what is happening at the annulus and just above the annulus. The grading of PVL is just like your valvular aortic regurgitation. The only thing that when you are grading the severity, you see the circumference of the leaking area just like a clock in a short axis view. If there is a less than 10% of the perimeter, then it is mild. If it is 20 to 30, it is moderate, and more than 30% of the perimeter is having the regurgitant check, then it is a severe PVL. right? Grading of PVL, that should also be checked by the holodiastolic flow reversal, like a severe AS, what we check. And device depth and understanding, you can check the under expansion of the valve frame during the TOE or during the transthoracic echo during the procedure. And as you can appreciate on my left, there is under expanded valve right here, and after post dilatation, whole the PVL thing goes away. So this also helps you to know whether the post dilatation is going to help or not, because in some cases you are actually not so super confident or super convenient to do the post dilatation. Post procedure and follow-up echo, only thing what we want to check is beside the orifice area, gradients and everything. Only thing I would keep you in mind is that when you check the alveolar diameter, just take it below the lower edge of the stent. And whenever you are taking the velocity, again, you start using the lower edge of the stent as a platform, as a point from which you start measuring the velocity, instead of just checking yourself in the valvular area. This is more applicable for the self-expanding valve, where the valve is actually very high as compared to what you see in the natural anatomy. So again, the dimensionless index, velocity index, they are all applicable same irrespective of the valve. And when you are checking the orifice area and everything, you have to understand that what is the thickness of valve frame. The leaflets are mounted inside, outside. If your TAVR platform is going to be intraannular or supraannular. This is just last 2 minutes. That's 1 minute. I'll just show you the interesting case of fallacies of 2D echo. Here you can see in this image, on an aortogram, there is a significant PVL, at least moderate, as we can see. And again, on the echo, we can see that on the long axis, there is a PVL. In the 4-chamber view, there is a PVL. And in the short axis, as you can see, there is a PVL. But I would just want you to notice one thing, that here on the right, with the color ones, that the color track is not following the territory of in and out. It's going outside and inside. We checked on a CT. It was actually because of this aortomitral tunnel, as you can understand from these views, that this is where the attachment of mitral is. This is where it is starting from the left cusp here, as you can appreciate the tunnel happening. So this case was not because of the PVL. So we changed the view, we changed the angle, and we could demonstrate the tunnel separately as compared to what we go for this. As you can see, there is a tunnel here. So whenever you are doing something on an echo, just keep your baseline CT dimensions and everything in mind when you are just taking a decision to post dilate, not to post dilate, what kind of size of balloons and everything should be in your mind. That's where the things start with. Thank you very much for your kind patience.